The trial is in adenocarcinoma of the esophagus and the esophago-gastric junction, which is an increasingly common cancer in the Western world. And the background for the study, the genesis, was the publication of the CROSS trial in 2012. And the question back then was, should that be the standard of care for this cancer? Or should pre or perioperative chemotherapy, which was used in many countries at that time based on good evidence, should that be tested in comparison with the very high impact CROSS regimen, which was a combination of chemotherapy and radiation therapy prior to surgery for patients presenting with locally advanced adenocarcinoma of the esophagus or junction. Phase 3 randomized clinical trial, just patients with predicted clinical T2 or T3, node negative or node positive, locally advanced disease. All patients had uniform staging with CT PET scanning. All patients who were undergoing multimodal CROSS regimen chemoradiation had RT quality assurance built into the methodology. And complications, surgical complications, which were an important secondary endpoint in this study, given some concerns about the impact of preoperative radiation on operative complications. Very detailed prospective recording of operative complications as per recently defined consensus definitions as per the esophageal complications consensus group were utilized. So they were three relatively rare or unique elements within the design of the trial. The primary endpoint was overall survival, and there was lots of secondary endpoints, including clinical response, disease-free survival, operative complications, as mentioned, pathological response rates, and many others. Key findings were the other element of design that's important. It began as a superiority design with the CROSS or the control arm being predicted to be superior than the perioperative chemotherapy arm, and with the first futility analysis that was done, and with a new trial, the FLOT-4 trial, with a new regimen, the FLOT regimen emerging during the trial period, and a protocol amendment being made, the trial design ultimately became non-inferiority. And the main findings, basically based on the first and second futility or interim analysis, was that there was no differences in the primary outcome of overall survival at this time point between the experimental arm, perioperative chemotherapy, which was either the MAGIC regimen or more laterally the FLOT regimen, or the control CROSS regimen. For both arms, the 3-year survival was very good, 56% for CROSS and 57% for the perioperative chemotherapy. And the hazards ratio was 1.02. So in terms of secondary endpoints, not surprisingly, but importantly, the pathological response rates were higher for the combination chemotherapy and radiation therapy, 16% versus 5% complete pathological response rate, 42% versus 12% major pathological response rate. The R0 resection status was significantly higher, 97% versus 83%, arm B versus arm 4. So those proxies of local regional impact that you would associate with radiation therapy as part of the treatment regimen were proven in this trial. However, interestingly, this did not translate into an advantage with respect to the primary outcome measure, the overall survival. The other secondary outcome measure I mentioned was operative complications. And again, absolutely no difference in the mortality or major morbidity or types of complications or severity of complications between both treatment arms, which is important because this is an area of debate and controversy from previous studies. Of esophageal cancer, so for esophageal and junctional cancer, well, it does a few things. Firstly, it provides good outcome data for either arm. So if somebody it provides clinical equipoise for the use of both arms. It provides support for groups, multidisciplinary groups, who practice one of these treatment arms. So for the control arm, the CROSS data, the pathological response rates, the outcome data, the operative data, the survival data is very consistent with the original CROSS trial and very affirming of the value of that approach in terms of what it achieves for the esophageal cancer patient. And that might even be more supported going forward by the recent emergence of the Checkmate 577 trial, which shows adjuvant nivolumab, so immunotherapy, post this type of regimen, resulting in a dramatically reduced disease-free, reduced recurrences compared to placebo control. So you can combine those two. For those, and for many groups, they prefer not to give radiation therapy, or their practice, both regionally or nationally, works much better giving pre or post-operative chemotherapy, or they have a natural preference for that for some other reasons, particularly seen in the UK and France and some other quarters and parts of North America. Well, again, you will find good data within this randomized phase 3 trial of very good outcome data at 3 years, no difference in primary outcome survival data at this time point. So the providing clinical equipoise in the first, if you like, large phase 3 trial that has addressed this question provides important data. However, it does not provide a clear winner based on the primary endpoint analysis. We will be continuing this survival analysis until at least the middle of 2022, but it's very unlikely given the absolutely matching first and second interim analysis, the second being after 143 patient deaths out of the 377 patients randomized. It's highly unlikely that this will change once the trial analysis is closed. What will be very interesting, however, will be the patterns of recurrence and to see if there's any clear way as to why, notwithstanding much better pathologic data for the control arm, that the overall survival rates are the same. So it's the systemic effect of chemotherapy counterbalancing the more local regional impact of the radiation therapy, and that can only be analyzed once we've all the data looked at when the trial is completed sometime next year.